Problem is that suppose one lady, Mrs. A B, having insulin dependent diabetes, pre-gestational insulin dependent diabetes, become pregnant, carrying pregnancy of 37 weeks, 37 weeks of pregnancy. Suddenly she is not feeling the fetal movement for last 2 days. For that she and her husband is very much anxious. What happened? Because she perceived fetal movement beforehand, but now she is not feeling fetal movement for last 2 days. They came to your OBG department, emergency. Sir, this is the problem. What is the cause? Is there any serious matter? They are very much anxious regarding the matter. With this history, you have to examine the patient and diagnose what is the case, and then investigations and management also. Probable diagnosis is intrauterine fetal death, because she lost fetal movement for last 48 hours. On examination, you are seeing that the fundal height is less than the period of amenorrhea, and by auscultation you are not finding the fetal heart sound. Then you place fetal Doppler, same thing, no fetal heart sound is audible by fetal Doppler. Then you have to proceed for further investigation like ultrasound. So what is intrauterine fetal death? By definition, intrauterine fetal death refers to a fetus having no sign of life in utero. In utero, no sign of life. Sign of life, that is the fetal heartbeat. Fetal heartbeat is absent. Intrauterine fetal death and stillbirth are traumatic and devastating events for the couple, their families, and the obstetrician also, because you are treating the patient throughout the pregnancy. Suddenly you have to disclose the matter, what happened. The couple will say, sir, you are examining the patient throughout the pregnancy, giving advices. Now you are saying that the fetus is dead in utero. So it is also a nightmare for the obstetrician also. The cause of death must be identified, explained, and further management must be discussed. The IUFD is two types, early and late. Early case of IUFD is from 20 weeks to 27 weeks. That is from 500 gram fetal weight, more than 500 gram. And late IUFD is 28 weeks onwards, that is fetal weight more than 1 kg, more than 1000 gram is late IUFD. The fetal death rate is around 35 per 1000 births in India and around 7.5 per 1000 births in USA. Incidence of IUFD in our country, in our country is more than developed country. There is gradual decrease in incidence of IUFD due to preconceptional care, better care throughout pregnancy, and prenatal diagnosis of major congenital malformation and their selective termination. Usually, fetal anomaly scan is done from 18 to 22 weeks. Fetal anomaly scan is done. By doing that, we can identify the congenital anomalies of the fetus like anencephaly, like that. And then we can take the decision for termination of pregnancy, spina bifida, or like that, major malformation. By doing termination of major malformation, incidence of IUD is becoming less. Not going to the term. Definition: intrauterine fetal death refers to a fetus with shown as no sign of life in utero. Stillbirth is defined as delivery of a baby after a period of viability with no sign of life and includes all fetal death occurring after 28 weeks of gestation, during pregnancy and during labor. In our country, this definition is accepted after 28 weeks is IUFD. As per WHO, stillbirth defining as a baby born with no sign of life at or after 28 weeks gestation or fetal weight more than equal to 1000 gram. This definition is followed in India. In United States of America, stillbirth is defined as loss after 20 weeks of pregnancy, and the United Kingdom it is defined as occurring after 24 completed weeks of gestation. Now, coming to the causes of IUFD. What are the causes? Why fetus becomes dead in utero? Causes of IUFD. Fetal causes. Fetal causes, number 1 is major congenital anomaly, chromosomal abnormality, and Rh isoimmunization, immunized immunized Rh isoimmunization, infection like congenital syphilis, parvovirus, cytomegalovirus, toxoplasmosis, parvovirus, rubella, varicella infection, and listeriosis, and non-immune hydrops. In infection, other causes like malaria, hepatitis are the causes of IUFD. So, fetal causes major congenital anomaly, chromosomal anomaly like chromosomal defect. Chromosomal defect like defect in number 13, 18 and 21. That may lead to anomaly, chromosomal anomaly, and ultimately they may lead to IUFD. So, these are fetal causes of IUFD. Placental causes, it is about 15 to 25% cases. cause is placenta. Through placenta, the fetus gets its nutrition. If there is any defect, like placental abruption, in abruptio placentae by accidental hemorrhage, placenta previa, through acute placental insufficiency. More separation in the abruptio placentae, more chance of IUFD. More separation, more chance of IUFD. Placental and cord abnormalities. Cord abnormalities like cord prolapse. Due to cord prolapse, fetus may be dead in utero. Like true knot around the neck and tight. All these causes can lead to IUFD. Infection, chorioamnionitis, intrapartum asphyxia. Intrapartum asphyxia may occur at any time. So that may cause IUFD. Multiple pregnancy, twin to twin transfusion syndrome, TTS, twin to twin transfusion syndrome, from one twin to other twin, twin to twin transfusion syndrome, one twin may die in utero. So multiple pregnancy is a cause. Fetomaternal hemorrhage, excessive coffee intake. Due to excessive coffee intake, the placental transfusion may be hampered and fetus may suffer malnutrition and ultimately death. Now come to maternal causes. 5 to 10% of causes is maternal cause. Maternal cause কি হতে পারে? না most common হচ্ছে diabetes, uncontrolled diabetes. Diabetes, hypertensive disease like preeclampsia, eclampsia, hypertensive disorder, especially preeclampsia, due to large placental infarct. Due to preeclampsia, placenta may be separated, accidental hemorrhage may occur, so fetus may die in utero, and markedly small placental size. Hypertensive disorder, placenta will be small. Diabetes mellitus, medical disorder like heart disease and renal disease. তারপর হচ্ছে অ্যাপলা সিন্ড্রোম, hereditary thrombophilias and APLA, antiphospholipid antibody. Obstetric cholestasis, due to severe obstetric cholestasis, IUFD may occur. Trauma, sepsis, acidosis, shock. Shock may happen due to any cause. Shock, maternal shock. Labor complications, hyperpyrexia due to any cause like malaria, dengue, etc. Hyperpyrexia itself can kill the fetus in utero. Postmortem pregnancy, if the pregnancy continued beyond 42 weeks. Nowadays that is not allowed, but in old days, in remote villages, postmortem pregnancy may occur. Pregnancy will continue for 42 plus. যত প্রেগন্যান্সি বাড়বে মানে পোস্টমার্টাম হবে কি হবে, liquor will be lessened, placental insufficiency will appear, and ultimately fetal death may occur. These are maternal causes: main hypertensive disorder, diabetes, APLA, cholestasis, etc., etc. Hyperpyrexia like malaria, dengue, etc. are unexplained cause. Unexplained cannot be explained. It is about 25 to 35% of cases. In other opinion, it may be up to 25 to up to 60% cases is unexplained. IUFD occurring nearer to the term that mostly comes under unexplained cause. Unexplained cause. Unexplained causes can be reduced to 10% by meticulous autopsy. By doing autopsy, what is the cause? We can diagnose and then we can take measure in future pregnancy. How will you diagnose IUFD? Patient came to you, says everything to you that fetus, she cannot feel fetal movement. How will you diagnose? It is a case of IUFD. When pregnant woman presents with absence of previously perceived fetal movement, সে আগে fetal movement regularly feel করতে পারত, suddenly she does not feel the fetal movement, so it should raise suspicion of IUFD. What are the symptoms? Patient may complain of decreased or absent fetal movements. Some may complain pain abdomen. Pain abdomen, in which cases? In case of abruptio placentae, renal causes, etc., pain abdomen, she may complain. Bleeding per vagina with or without uterine contraction, antepartum hemorrhage, accidental hemorrhage, placenta previa. In those cases, bleeding per vagina may occur. And pregnancy symptoms may recede, like in pregnancy there may be breast tenderness and a formation that will regress. Fetal heart, uterine height will be regressed. In fetal causes, another thing is that FGR, fetal growth restriction, is a major cause also. Fetal growth restriction. In that case, if you cannot diagnose fetal growth restriction in timely, if that continues, then IUD may happen. Signs. Regression of pregnancy signs like breast changes. Breast changes, যেগুলো Montgomery's, tubercle, etc., etc., that signs regression. Fetal heart sound are not audible on auscultation or by stethoscope or Doppler, and that will be confirmed by ultrasound. By doing ultrasound, there will be no heart movement. That is confirmed IUFD. And other signs, radiological signs may be there, like Spalding sign, like Robert signs, etc. Per abdomen, decrease in fundal height, decrease in tone of uterus. Braxtonic contraction are not felt easily. What is Braxtonic contraction? Now, it is an irregular uterine contraction, low volume contraction that do not lead to pain abdomen, Braxtonic contraction. In lump abdomen, you place your hand over the lump. If you feel Braxtonic contraction, you may say this is pregnant uterus. But in case of fibroid uterus, there will be no Braxtonic contraction. And also the fetal movement. In case of pregnant uterus, you can feel the fetal movement. In case of fibroid uterus, no fetal movement. Decrease in fundal height, decrease in tone of uterus. Uterus will be flabby. During palpation, fetal movements are absent. Egg cell crackling feel of fetal head appears after many days of IUD. Usually 7 to 10 days of IUD, there will be softening of skull bones and Spalding sign will appear. If you feel the fetal head, then you can feel the egg cell crackling. ডিম ভাঙলে যেমন নরমে লাগে সেই রকম ফিলিংসটা পাওয়া যেতে পারে। So these are the signs. Pathology. Depending upon the degree of maceration by careful examination of dead infant, time of death can be determined. Only skin reddened, we can say the fetus become dead 6 to 8 hours before. Skin slippage and peeling of skin 8 to 12 hours. That is grade 2 maceration. Extensive skin peeling, red serous effusion in chest and abdomen in 2 to 7 days, grade 3 maceration. After 5 to 7 days, aseptic autolysis of the ligaments and liquefaction of other structures like brain occur. These changes are basis of typical radiological of intrauterine death. Radiological finding. What will be the radiological finding? Number 1, Spalding sign. What is Spalding sign? Softening of skull, brain matter and overlapping of skull bones, irregular skull bones. What is Robert sign? Gas in heart chamber, blood vessels and joints also, Robert sign. There will be hyperflexion of spine. হবে. There will be crowding of rib. রিবগুলো সব একদম কাছাকাছি চলে আসবে, crowding of rib. These are all radiological findings of IUFD cases. Investigations, ultrasonography, absence of fetal cardiac activity, reliable evidence of fetal death, scalp edema, and hydrops হয়ে গেছে, তাহলে তুমি বলতেই পারবে যে IUFD. Scalp edema, collapsed cranial bones which are overlapping also provide the cause of death in some cases like abruption, oligohydramnion, sign of fetal hydrops. All can be seen by ultrasound. Straight X-ray abdomen usually not done today. We do ultrasonography, better investigations. Spalding sign. Spalding sign. There is overlapping of skull bone, overlapping of skull bone. Seen after 7 days after death, collapse of fetal skull with overlapping of bones due to liquefaction of brain matter and softening of ligamentous structure. This is Spalding sign, radiological sign of IUFD. Halo sign. Halo sign, abnormal increase of cranial soft tissues due to maceration. Halo sign, X-ray তে বুদ্ধোজ পজিশন পাওয়া যায় এক্স-রে করলে। নাওএডেজ যে এক্স-রে করা হয় না। রবার্ট সাইন, ফার্স্ট সাইন অফ IUFD. Intrafetal gas within the heart, great vessel joints. Uncommon but reliable sign seen after 12 hours of IUFD. Ball sign, hyperflexion of the spine requires several days. Mild degree of curvature of spine may mislead in living fetus. Hyperflexion होते हैं, hyperflexion. Crowding of rib shadow, that is concertina effect. Concertina effect. Crowding of rib. Maternal evaluation in IUFD. মাকে তো দেখতেই হবে কজ কি আছে, ডায়াবেটিস না হাইপারটেনশন না কি আছে কজ, সেটা দেখতে হবে। ম্যাটারনাল ইভ্যালুয়েশন, ম্যাটারনাল হিস্ট্রি, ক্রনিক হাইপারটেনশন, ডায়াবেটিস, এসএলই এগুলো আছে কিনা মায়ের সেগুলো দেখতে হবে। ম্যাটারনাল ইভ্যালুয়েশন, ফর দ্যাট ইউ হ্যাভ টু ইনভেস্টিগেট। Past obstetric history, history of previous stillbirth is there or not? Recurrent pregnancy loss, previous infant and development and structural abnormality. পরপর বাচ্চা হয়েই যাচ্ছে, abnormal, congenital anomaly, etc. So history taking, past obstetric history taking is very much important. And chronic hypertension and diabetes, all these may lead to especially hypertension may lead to fetal growth restriction diagnosed. So placental insufficiency will continue, ultimately fetus will die in utero. FGR is a major cause of IUFD. Previous gestational hypertension or diabetes, previous macrosomic or growth retarded babies, previous placental abruption, hypertensive disorder, all history to be taken and all to be evaluated. Family history, is there any family history of IUFD cases? Current pregnancy, BMI, pregnancy weight gain, is there any multifetal pregnancy, that is twin, placental abruption, preterm labor or rupture of membrane, infection, chorioamnionitis, fetal abnormalities or ultrasound, fetal growth restriction and fetal structural anomaly. Fetal growth restriction and fetal structural anomalies. Examination, blood pressure, proteinuria, uterine size, bleeding, blood test, bile, screening for diabetes, antiphospholipid syndrome, clear Betke test to rule out massive feto-maternal hemorrhage, indirect Coombs test to rule out RH isoimmunization, coagulation test, If coagulation test is usually done in case of DIC, usually DIC occur after 3 to 4 weeks of IUFD, after event. Platelet count, plasma fibrinogen degradation product, if indicated, are test for specific infection like parvovirus, toxoplasma, cytomegalovirus, etc. Cytomegalo, toxo, parvo. Fetal evaluation. Fetal evaluation is very much important. You have to examine the fetus, length, breadth, photo of the face of the baby, everything, any congenital abnormality, examination of placenta, cord, membrane, examination of the placenta, cord, membrane along with a fetal postmortem examination is very much important. Is there any chromosomal abnormality? Is the single most useful test in the evaluation of stillbirth. If the patient party does not agree, you have to examine the baby clinically and take photos that may help in planning for future pregnancy. Gross examination may reveal one of the following causes: placenta, weight, retroplacental clot, suggestive of abruption, filamentous attachment of the cord, vasa previa, infection, meconium staining, membrane, meconium stained or cloudy, thickening of membrane, fetal foul smell is there. If there is infection, chorioamnionitis, there will be foul smell. Amniotic fluid, color, volume, consistency. Cord, true knot, signs of umbilical cord thrombosis or false knot, entanglement around the neck, গলায় প্যাঁচ হয়ে যাওয়া, arm, legs, pull-ups of cord, length of cord, hematoma or strictures of the cord, Wharton's jelly, normal or absent, all these to be evaluated. Postmortem examination. Postmortem examination is very important part of investigation for the etiology of stillbirth. Final diagnostic documented during postmortem: weight, length, head circumference, abdominal circumference. By doing head circumference, abdominal circumference, you can diagnose, is it a case of FGR? You can diagnose. Measurement of limbs, structural abnormality, dysmorphic features, relevant negative findings, detailed photograph of entire fetus including face, gross and histological examination of placenta. Now come to management of IUFD. In most cases, patient may go in labor, but nowadays patient will say, I will not bear the dead fetus in my utero. So, sir, doctor, please deliver my baby. What are the methods? How will you manage? If there is no immediate medical complication putting the mother's health at risk, the couple should be allowed to make an informed decision about the timing of delivery. At the same time, the couple should be reassured about the fetal demise without not negatively impact on the mother's health. Choice of method and timing of delivery depends on gestational age at which fetal demise occurred, history of a previous cesarean, if there is previous cesarean section, one cesarean section or repeat cesarean section, that all will be all will depend mode of delivery, maternal preference also. Expectant management. Most of the women will deliver spontaneously within 2 to 3 weeks of IUFD, but it may lead to severe maternal anxiety because she will to bear the dead fetus in her utero. Most couples will not choose expectant management. Vaginal delivery is the preferred route unless there is definite indication for cesarean section. What are the indication? for cesarean section in case of IUFD. If there is transverse lie, if there is major degree placenta previa covering the internal os, and if transverse lie, major degree placenta previa, or prolongation of pregnancy beyond 2 to 3 weeks, wish of the patient due to psychological upset, falling fibrinogen level, onset of uterine infection, immediate delivery indicating conditions such as severe preeclampsia, eclampsia, placental abruption, ruptured membrane, chorioamnionitis, intrauterine induction in IUFD. কি ড্রাগ ইউজ করতে পারি না ইউটেরোটনিক, দ্যাট ইজ অক্সিটোসিন, অক্সিটোসিনের টার্ন উইথ ফেভারেবল সার্ভিক্স, ফেভারেবল সার্ভিক্স আছে তাহলে অক্সিটোসিন ড্রিপ দিতে পারি, অক্সিটোসিন ড্রিপ। ইন কেস অফ IUFD আমরা সাধারণত অক্সিটোসিন অনেক বেশি ইউজ করি, দ্যাট ইজ 10 ইন্টারন্যাশনাল ইউনিট, 10 ইন্টারন্যাশনাল ইউনিট। ইন কেস অফ induction of labor in living fetus, we will use 5 units in 1 bottle NS, 1 bottle of NS RL, usually NS, and drop from 30 drops onwards. I will increase the drop of oxytocin drip. But in case of IUFD, আমার কি হচ্ছে লিভিং ফিটাস নয়, তাহলে আমরা হাই ডোজ অফ অক্সিটোসিন ইউজ করব, ইউজুয়ালি 10 units, 10 units in 1 bottle we will use. If the cervix is ripe, for ripening of cervix, if the cervix is not ripe, we can ripen the cervix by giving the prostaglandin gel or tent or fallopian Foley's catheter also. Oxytocin at term with favorable cervix preceded by cervical ripening if needed. Misoprostol less than 28 weeks. Dose ki hobe? Misoprostol 100 or 200 microgram 4 hourly, maximum of 4 doses. 100 or 200 microgram 4 hourly, maximum of 4 doses. তার বেশি দেয়া যাবে না। More than 28 weeks, কম 50 microgram 4 hourly, maximum of 6 doses. 6 doses. Avoid in case of previous cesarean section. If there is previous cesarean section 1 or 2, you have to avoid the misoprostol. Misoprostol avoid করতে হবে, কারণ there may be a chance of rupture uterus. Also, rupture uterus. Mifepristone plus misoprostol. If you add mifepristone, it will shorten the induction delivery time. For that, 24 to 28 weeks, 200 milligram of oral mifepristone, followed by 48 hours later, তার 48 ঘন্টা পরে আমরা মিসোপ্রোস্টল দিলাম 400 microgram every 3 hours. In that case, কি হবে না induction and delivery time will be less. Foley's catheter for cervical ripening. In women with a previous cesarean section, if we place Foley's catheter, plain Foley's catheter through the cervix, it will ripen the cervix ultimately. And কি করছি আমরা বেলুন ফুলিয়ে দিচ্ছি তো, labor will start due to separation of the membrane and liberation of prostaglandin. Labor will start and ultimately Foley's catheter will come out through us and patient may go in labor and ultimately labor occurs. In case by doing Foley's catheter, many cases of IUFD is delivered nowadays. Indication of C-end section in IUFD. Major degree of placenta previa, that is covering the internal os. Transverse line, 2 or more previous scar on uterus, that is the scar C-end section, 2 or more. A significant macrosomia, অনেক বড় বাচ্চা, vaginal delivery হবে না, তাহলে তোমাকে পেট কেটে বের করতে হবে। Postnatal management, counseling of couple, a possible cause of fetal demise, risk in next pregnancy, suppression of lactation, মরা বাচ্চা বেরিয়েছে তাহলে কি হবে, এদিকে তো বুকে দুধ আসবে, suppression of lactation by cabergoline 1 গ্রাম, 0.25 এর পাওয়া যায় আর 0.5 এরও পাওয়া যায়, 0.5 এর দুটো ট্যাবলেট একসাথে বা তুমি 12 আওয়ার্স অ্যাপার্টও দিতে পারো, 0.5 total 1. Suppression of lactation, cabergoline 0.25 milligram BD. RH negative women, সেখানে তোমার ব্লাড গ্রুপ তো করা যাচ্ছে না, তো সুতরাং তোমাকে অ্যান্টিডি দিতে হবে, 300 মাইক্রোগ্রাম অ্যান্টিডি। Follow up visit, plans for future pregnancy, preventive measure if any, contraceptive advice. In case of IUFD, major causes, say some major causes, mostly unexplained. Then comes FGR, fetal growth restriction. Then comes hypertensive disorder, diabetes, and congenital anomaly. এরপর আস্তে আস্তে সূক্ষ্মভাবে ভাবতে থাকো placental causes, fetal causes, maternal causes, RH negative, twin pregnancy, etc. causes. Okay? কারো কোশ্চেন থাকলে বলতে পারো।